Good afternoon, ladies and gentlemen. And once again, I thank Dr. Abdullah Shihab for asking to give me a talk in this year of cardiology meeting. And I am Dr. Amrish Agrawal. I'm a senior consultant in cardiology at Future Hospital, UAE. So there has been an old saying for a long time, which we heard from the childhood, that prevention is better than cure. And that is the reason all the societies and guidelines over the years have come out with a paper on prevention. And the latest is the European Society 2021 guidelines, which were released few months back, which came in collaboration with the 12 medical societies. And these guidelines are a little bit important for the reason is that our demographic population in UAE is more aligned with the European way of thinking, European way of living and the European food style. So the European guidelines, apart from creating set of recommendations at the level of population as well as the level of individual, emphasized more on the personalized cardiovascular disease prevention instead of one size fit to all, because the chairperson and the members of the guidelines, they recognize the fact that in clinical practice, no two people are the same and the people are very, very different. So the guidelines once again emphasize on the healthy lifestyle. So the healthy lifestyle includes that good diet, not smoking, and the regular exercises. The first step in a patient with healthy person is to estimate cardiovascular risk. And for this, European Society has made tremendous changes, which are totally different from the previous version. The estimated cardiovascular disease risk can provide information for tailored intervention at the individual basis. And this is not just important for the apparently healthy individual. This is also important for the older persons in patients with the established cardiovascular disease or diabetes mellitus, where more further information can be given for the level of intensification for the underlying risk factors. So the first step, obviously, is the interference regarding the diet. And the European guidelines recognize, like other societies are coming to this conclusion, that we have to take a more plant and less animal-based food pattern. That means there should be reduction in the red meat to not more than 350 grams per week. And among them, particularly the fatty fish is recommended because it is a source of essential oils and high quality fatty acids. In addition, they recommend 30 grams of unsalted salt nuts per day. The guidelines also recommended a low salt intake of less than 5 grams per day and increase in the fiber to 30-35 grams per day to enhance the gut biotome, and to take at least 200 to 400 grams of fruits and vegetables per day. That means we are talking about 2 to 3 servings of fruits and 2 to 3 servings of vegetable. The guideline recognize the fact that substitution of saturated fatty acid with the monounsaturated fatty acid and the polyunsaturated fatty acid can cause reduction in of the cardiovascular risk up to the tune of 25%. So in my opinion, this is one of the substantial recommendations which we have to actually implement in our practice, because as a clinician, we talk about drugs, but we hardly talk about a change in the food and the change in the dietary pattern, which are an important component in the general population. So we all know what to do in the population with atherosclerotic cardiovascular disease and diabetes mellitus. The things are clear, the guidelines are there, and we keep on hearing in the meeting talks regarding that, and we heard from the previous speakers. But the things are not clear for those people who are apparently healthy people, for example, our family members, ourselves, and the people who come to the clinic with the non-cardiac conditions, as well as those people who are older, more than 70 years of age. Now, this population, older population, more than 70 years of age, received special attention by the European Society guidelines. The reason is that age is the dominant driver of cardiovascular risk, and the older people come in the high risk category just because they are old, even though they may not have diabetes or they may not have underlying atherosclerotic cardiovascular disease. The opponents argue that the risk should not be treated when they are essentially age-driven. However, there are lots of people who look at the population table and they say that many preventive strategies are still effective at the advancing age in terms of postponing mortality and morbidity. So the first step when the person comes to you who is a healthy, apparently healthy person without underlying atherosclerotic cardiovascular disease or diabetes mellitus is to advise them lifestyle modification, which includes stop smoking, lifestyle recommendations, and keep universally systolic blood pressure less than 160 millimeters of mercury. Then we look at the age of the person, and if the age of the person less than 70 years of age, then we apply a scoring, which we call it the score 2, So these are the new recommendations, and this is the important component of this talk, that the recommendation by the guidelines is to use a new score risk, which is called a score 2, for those people less than 70 years of age, and to use a new recommendation called a score 2 OP, means older persons for more than 70 years of age. Now, what is the score 2 and the score 2 OP? This is a totally dramatic change which the guidelines are recommending for such a long time. From 2003, we have been using the score charts which are applicable from the age of 40 to 65 years of age, and which talk about risk of having an 10 years fatal cardiovascular event. So the fatal cardiovascular event means the person should have a death. And this concept, the guidelines have abandoned, and they have come to the concept which is being used in the score 2 and the score 2 OP, because from that time, a lot of changes have occurred, particularly the European countries, because these guidelines, European guidelines, have undergone epidemiological, economical, social, and neurological transformation, and modern therapies have improved health outcome. So it is likelihood that the person may not have an absolute mortality, but may have a cardiovascular event. So the guidelines abandoned the concept of fatal cardiovascular event and have come with the concept of 10-year risk of first onset fatal and non-fatal cardiovascular disease. That means any event will classify as an absolute event. And this concept has been put in the score 2 and the score 2 OP, which is actually a new algorithm which been derived, calibrated, and validated. So how this algorithm was derived? This algorithm was derived by using the data from 45 cohorts in 13 countries, which included nearly 3/4 of a million individuals of nearly 30,121 cardiovascular disease event. So the tables were derived, and these tables were validated in the data in 45 prospective countries. So 45 prospective cohorts were used in 15 European countries, and the number of patients in which this data was validated was huge, nearly 1.1 million. And this particular score 2 better estimates the total burden of cardiovascular disease as well as the risk discrimination, particularly in the younger individual. The score old charts were actually difficult because they were underestimating the risk in the younger individual and overestimating the risk in the older individual. Older populations are a tricky population because as we become older, we have a more higher risk of developing cardiovascular disease, but the traditional risk factors such as the hypertension and lipid profile have a less effect or less negative effect in the older population as they have on the younger population. And second of all, as the time goes, the older population, non-cardiovascular death from cancers, from frailty, from orthopedic fractures, DVT, they increase much more higher in proportion than that of the cardiovascular disease. So the older populations are to be tackled more differently. And for that, the European Society came out with a new set of recommendation, which is called the Score 2 Older People Model, which was derived from the low-risk cohort of Norway, which were 28,000 participants with an extensive follow-up. And they were recalibrated to the 4 geographical regions of the European Society and validated in nearly 338,000 individuals. The score 2 chart obviously do not apply for those people who have documented atherosclerotic cardiovascular disease or diabetes mellitus or high-risk conditions. So they are applicable for those people more than 70 years of age without any high-risk population. So these European charts are applicable to these 4 geographical regions. And you can see all these countries are located in the European regions. But what about the Middle East? We mean the Middle East come into the area of this area, and this is at all not represented in the European Society guidelines. So the question comes, what type of scoring charts are applicable to the UAE population? Shall we apply low risk, shall we apply moderate risk, or shall we apply the very high risk? And there is a paucity of data with regard to this. However, there is one paper which was published, which looked at the database from Abu Dhabi, that is called the Salama database, which came last year, and which looked at a small population database of nearly 2,000 participants without diabetes mellitus and without cardiovascular disease. And they were able to show that it is the score high risk which correlated best among all the risk factors. They looked at the American pool cohort and they looked at the NICE criteria, as well as they looked at the score charts and the Framingham scores. And this was actually their risk correlation was the best, and this was nearly 0.47%. So it appears that from this paper that the score high risk charts are applicable to the UAE population. So once you divide the risk and you calculate the score, you get a numerical value, and you can put this numerical value in this risk categories. And those risk categories, which is high cardiovascular risk and the high cardiovascular risk, which obviously are dependent upon the age. So the lower category cutoffs for those people who are younger, and a higher category cutoff for those people who are older, you can decide that what type of management for the underlying risk factors and what type of intensity you require for the individual patient. So the first step for when you see a patient should look at the first step, if you after calculating the risk, is to bring the systolic blood pressure to less than 140 millimeters of mercury and LDL level less than 2.6 millimole, which is less than 100 milligram per deciliter. So this is the step one goal. So this is applicable to all those people who classify the score of high risk and the very high risk. And low to moderate risk, you can take an individual approach depending on the patient preferences and the clinician preferences. Once you have the step one approach, obviously the next step is to have the personalized approach regarding the patient treatment. And this personalized approach, you have to look at the intensified treatment based on the 10-year cardiovascular risk, which is the score 2 chart, lifetime cardiovascular risk, comorbidity, frailty, and the patient preferences. In that case, you want to bring down the systolic blood pressure to less than 130 millimeters of mercury, and to bring the LDL level down to the underlying risk factors, which can be less than 70 milligram per deciliter or less than 55 milligram per deciliter. So how do we decide which category our patient comes to? So we have the two main traditional risk factors which we attack. One is hypertension and one is diabetes mellitus. With regard to hypertension, the society recommends that anybody with a grade 2 hypertension, which means that the systolic and diastolic blood pressure of readings of 160 by 100, drug treatment is recommended. And we know from the previous European Society papers that in that case, you want to use a drug treatment with a combination therapy right away. However, for those people with a grade 1 hypertension, the treatment decision is based on the absolute cardiovascular risk, estimated lifetime benefit, and the presence of hypertension mediated end organ damage. And this is a class 1 recommendation. So the cutoffs which are given in the preventive guidelines are aligned with the European Society 2018 paper on hypertension. And we can see the recommendation is that you want to give the blood pressure more than 120 millimeters of mercury and less than 130 millimeters of mercury in practically all the categories. As regard to diastolic blood pressure treatment targets, it is less than 80 millimeters of mercury for all treated patients. So these hypertension guidelines are actually aligned with the European guidelines of 2018 guidelines. What about the lipid parameters? So lipid parameters, it is clear, it is set, we know what are the cutoff, we have seen many talks about it, but the guidelines, they say that if you are not able to reach the targets with the maximum tolerated dose of statin, so it is not the maximum intensity statin, it is the maximum tolerated dose of the statin, then a combination therapy of azacitidine is recommended, and this is the class 1 recommendation. You can escalate to PCSK9, which is a 2B recommendation, and those people which are at risk, in which you are not able to reach the LDL cholesterol level. Particularly, this 2021 paper addressed those people more than 70 years of age, and the guidelines said that initiation of statin treatment for the primary prevention in the older patients more than 70 years of age should be considered if the risk is high risk and above. So high risk and very high risk, that means we have a cutoff level of 7.5%. Anything more than 7.5%, you can consider as a 2B recommendation for the statin treatment. So why this is a 2B recommendation? Why this is not a 2A recommendation? As I discussed in detail in my chapter of this book of advances of statin therapy in elderly, the elderly is a difficult group to see because the data is not there. There is a paucity of data with regard to the treatment outcome in the elderly. And if you see the number of primary prevention trials in the elderly, few trials included population more than 70 years of age. And one trial which stand out was the Prosper trial, which came long time back, which came like 20 years back, included population which is more than 70 years of age. So 100% of people more than 70 years of age showed no change in the primary endpoint. Similarly, data from Jupiter and the Hope. So these trials were large trials, included population nearly 17,000 and 12,000, and nearly 25% to 35% population for more than 70 years of age did not show any benefit in the primary outcomes with regard to this elderly population. So it appears the data for the elderly is a little bit dicey, and the people were not clear what to do with this elderly population till the data came out from the CTT, which is Cholesterol Trialist Collaboration Group trial, which included a meta-analysis of 28 randomized trial. The reason for randomization is that individual trials are not sufficiently powered to pick up the benefit outcome in the elderly population. And this data from the cholesterol trial showed that there is no heterogeneity in the reduction of cardiovascular event in the lipid-lowering therapy, whether you are looking at the younger population or you are looking at the older population, as seen in the right-hand side upper graph. The older population derive as much benefit as the younger population. And when these trials were further analyzed, excluding heart failure trials and those people who were underlying CKD, the benefit persists. Further, for the first time, the trialists were able to show the reduction in the all-cause mortality across all age group, whether younger or older. You are able to get nearly 12% reduction for each millimole reduction in the LDL cholesterol. And more importantly, the meta-analysis showed there was no increase in the incident cancer or cancer death in the elderly. So the data reduction of the cholesterol by the oral medicines and by other medicines were perfectly safe in the elderly population. So it appears now the guidelines are now very clear about the European Society for the older population, more than 70 years of age, that these people should be treated with the statin in the same way as that the younger people. That means escalation with the maximum tolerated statins. You have to understand the older population, they are able to prone to a muscle side effects. They have a locomotor problem, so they may perhaps tolerate a lower dose of statin. You can try combination therapy. And they also say very clearly that the initiation of statin therapy for more than 70 years of age should be considered as a class 2B recommendation. And it is recommended that the statin to be started at the low dose if there are significant renal impairment or the potential for drug interaction. And I will add to it if there is a suspicion of myopathy or muscular side effects with the statin therapy, you have to use a low dose of statin. In addition, the guidelines have two important recommendations regarding the risk modifications and the physical exercise. The society understands the importance of stress symptoms and the psychosocial stress to modify cardiovascular risk. We have seen time and again, young people from the Indian subcontinent, when they come to a Middle Eastern region, because of tremendous stress, they develop a myocardial infarction. So the assessment of the stresses should be considered, and this is a class 2A recommendation. In addition, society also recommends use of calcium scoring to improve risk classification and the treatment decision threshold. Plaque detection of our cardiac ultrasound can be alternative when the calcium scoring is not available or is not feasible. In addition, we have to consider some people's ethnic subgroups for the risk calculation. So multiplication by the calculated risk by RR for the specific ethnic subgroup should be considered. That means you have to give a weightage for somebody with the Indian subcontinent, Asia subcontinent, and here to multiply. This is not clear what multiplication factor we use. And we in Middle East have to come out with their own tables at what type of multiplication we have to use for the risk calibration for our population. Then last point I will emphasize about physical activity. It is recommended for all adults for all ages to have nearly 150 to 300 minutes of moderate intensity physical exercise every week to reduce all-cause morbidity. It is recommended that we have to reduce sedentary time. That means less time watching television, less time watching WhatsApp, and should have some generalized physical activity all throughout the day to reduce the cardiovascular risk. In addition to the isotonic exercises, the guidelines recommend performing resistant exercises in addition to aerobic activity is recommended for 2 or more days a week to reduce all-cause mortality. And there can be multiple roles for the group: individual education, behavioral change technique, counseling. And if you go to the gym, it is a powerful motivator, because when you see other people walking around you, you can be actually more motivated to do this exercise. With this, I come to the end of the talk by summarizing certain things. The first step of cardiovascular risk reduction is to have lifestyle modification. That means stop smoking, healthy diet, keeping the blood pressure level in 160 for all, and to use calculators to define the individual risk for each person. And now in 2021, the guidelines recommend use of SCORE2 and the SCORE2 OP calculator for those people more than 70 years of age. We have to remember there's a different cutoffs for risk thresholds for different age categories. For example, for the same risk 2.5 for the same person less than 750 years of age. 2.5 will bring them into the risk categories, and more than 7.5 will bring them the high risk categories. But for those people who are older, this cutoffs can be revised to 15%. Explicit treatment considerations by the intermediate risk, in which includes the lifetime benefit from the treatment. We can use calcium scoring. We can use certain other categories to determine if this person falls in which risk category. And lastly, the most important is to use a stepwise approach for the treatment target. Guidelines are given very clear indication what is the step 1 approach and what is the step 2 approach. So with this, I come to the end of talk, and thank you very much for your kind attention. I'll be happy to answer any questions which you have.